Thank you everyone for coming from a variety of worlds, the VA simulation world and a lot of other places that are obviously interested in this topic. I'm Hollis Day. I'm actually the medical director for our standardized patient program at Pitt. And I'm going to talk today a little bit about a couple of different things. One is obviously teaching with and learning from standardized patients as well. And as we go through that journey, I'm going to talk a little bit more about, first of all, the historical evolution of standardized patients, which have actually been around for quite a while now. I'm going to talk about some points to ponder in developing cases, which is clearly the heart of what we do. We are actually going to have the opportunity to generate a case skeleton. And I emphasize the word skeleton not only because it's Halloween, but because this is very much a very down, quick, and dirty exercise to get you thinking about it. And then we're going to talk a little bit about some of the challenges and opportunities to using SP methodology. And I would really like to encourage the faculty who are here, especially young faculty, who are thinking about an area of scholarship, that this is actually a very rich area for scholarship down the line. So I think anybody in this room has probably seen this about 1 million times. Miller's hierarchy of how we think about assessing people and looking at people. At the nose level, you know, anybody can kind of tell you something. You can do an MCQ test or something like that. The knowing how and the showing how, the holy grail of assessment is ultimately what do you do in practice, in real life, when nobody's technically watching you? And how do you assess that? And that has actually been an issue for many years. We're not quite there yet, but I'm going to talk a little bit later about how we might get there. But at the moment, where we kind of are is this shows how, and that's actually where SP methodology comes in quite a bit. Now, as we think about assessment, in the past, first of all, who in here had to take Step 2 CS? Anybody? Now I can date you. I can date your training by that. Step 2 CS, for those who did not have to go through that experience, is the clinical skills exam, the National Clinical Skills Exam, which we'll talk about. But prior to that experience, most of what the rest of us in the room had to go through were a variety of assessments that were typically done with quote-unquote real patients. One very meaningful experience to me was, if anyone remembers Warren Coates at the VA, he did my CEX when I was an intern, my live one, which was supposed to be a relatively brief half-hour experience that turned into 2 hours of live patient experience and dead intern by the time it was finished. So the assessment in the past has clinically been done with real patients, whoever happens to be around, both long and short case format. And there have been different assessors, so it's whoever happens to be on the ward, whatever patient happens to be around, whatever student happens to be around. And there's been some question about bias in that, in terms of how valid those assessments may be. It also, in the past, has measured a relatively narrow therapeutic window of competence and skills. That is, maybe you're really good at taking care of patients or talking to patients with cirrhosis, but that does not necessarily mean you're equally good at talking to someone who has schizophrenia. So it's just based, that assessment was based predominantly on whoever was there. So in 1964, actually, this is how long this has been around, Dr. Howard Barrows in the UK was actually in charge of getting patients for their national neurologic and psychiatry boards. So they had oral boards, they had a clinical exam at that time, and he was responsible for grabbing whoever he could to be on these boards, live patients, that the residents then had to examine and perform their exam, their history, spit out a oral presentation, and then they would be judged on this. And he realized, well, gosh, you know, I kind of, again, get who I get. I don't have a standard cache of this, and I can't necessarily test the things that I want to test. So he grabbed a model from the art department where he was, and he taught her how to simulate a bilateral Babinski sign, some unilateral blindness, and a few other neurologic findings, some gait issues. And he used this person to standardly, he trained her, and to standardly reproduce that performance for candidate after candidate after candidate. And what he called this person was a programmed patient, at least initially. Realizing that that methodology helped to fill in some gaps and actually make it more convenient to set up a true exam and a true standardization of exam. About 20 years later, Jeff Norman, who many of you know and is a great sort of psychometrician out of all of this, called them now standardized patients, because what he said was, this is a methodology to reliably and consistently repeat a performance for a large number of learners. And that's actually how the term standardized came in. That is, any person who walks into a given case room will get exactly the same response to the same questions and the same physical exam findings. The integration term has also been used simulated patient, and that is where there is a case, but there may be a little bit more free-flowing dialogue, not wildly deviated from what the learning objectives are, but this is not exactly the same answer, exactly the same finding. This is kind of going with the flow a little bit more. And you will find in the literature that simulated patients and standardized patients are often interchanged. In about 2008, there was a poll that was done, and at that time, 96% of U.S. Schools had an integrated OSCE at the end of their third year, beginning of the fourth year, that looked at history taking and physical exam. Interestingly enough, and they also talked about an integrated exam as well as exams in the clerkships. Currently, only 25% of neurology clerkships actually have OSCEs, and given the fact that this is where it started, it was kind of interesting. And about 80% of medicine clerkships actually have an OSCE somewhere in their curriculum, and we'll talk more about OSCEs in a bit. Because the methodology was so popular, because it was so prolific, in 1991, the Association of Standardized Patient Educators became into existence and has now become a very robust international society that actually has been trying to develop certification standards for SPs down the line, and we'll talk a bit about that. So that's kind of the background of where we are. The real reason that this came into effect, and thinking about it as educators, is that there's a real need for concordance between curricular objectives and assessment. That is, there's really no point in, one may argue, in having objectives if you can't figure out if you're meeting those objectives. And this is one way to do that. Secondly, there are often gaps in curriculum. Again, who you see on the wards is who you see on the wards, and depending on where you are, you may be missing some things. And so there are many ways to address those gaps. We've certainly in this forum talked about VP Sim patients, computer simulation, simulation down at Weiser, but there are other ways to address those gaps, and standardized patients are certainly one of them. And it's really hard to talk to a mannequin. So in terms of some of the more challenging competencies, things like communication skills, decision making, patient care, that kind of thing, this is why standardized patients have been more widely used. So what do we do with them? Well, we teach. Most of what we do, any of you who've been in this room have taught in Intro to Medical Interviewing, Advanced Medical Interviewing. We also have formative assessments. Right now, every clerkship has an OSCE of some sort. Some of them are formative, some of them are summative. And the summative assessment, the big summative assessment that we have here is something called our Clinical Competency Assessment at the end of the third year. It is a mock Step 2 clinical skills exam. It almost exactly replicates what is on the board, at least as much as the board will give us any information about what is on the board exam, but we think we're pretty close, and at least our students have told us when they come back, darn, you guys are good, because they say that actually our exam is probably a little bit harder than the national exam, which I am totally fine with. So, how do we use standardized patients? Well, we can certainly use them in a small group setting, and anyone who has done any kind of the interviewing classes, that's pretty much what we do. Certainly one-on-one is an option, or two-on-one pairs. We use that often in teaching, tobacco cessation, alcohol use. We have telephone cases that are actually used in family medicine. We have a longitudinal kind of telephone curriculum that they're using standardized patients for. I talked about the Holy Grail of what you're doing in practice. There are actually a few places in residency that are using unannounced standardized patients, which has an enormous number of logistical challenges, as you can well imagine. But these are patients who go in with a particular complaint. The residents know that they're coming at some point in the next 6 months. And a new patient shows up on their schedule, as they are want to do, and they go in with a particular complaint, and when they come out, they are actually, and they have a chart and everything. One of the big logistical hurdles, I might add. But when they come out, then they actually grade the resident on the interaction. And the resident does not know that that was a standardized patient. So that is becoming a little bit more of where the future is going. But at the moment, probably one of the things that we as educators are doing a lot of and are concerned with is the Observed Structured Clinical Exam, or the OSCE that I was talking about. The traditional OSCE is multiple stations. The one that we have is 10 stations. The national exam is 12 stations. The original Canadian exam that this was built upon or modeled off of was 20 stations long. Okay, think about that for those of you who went through this exam. 20 stations. Ugh, couple of days. Sounds really bad. But each of those stations actually has a few objectives that is related to that case. And there is a presenting scenario that the students read prior to entering. It's usually a 15-minute encounter. That's based for us on the national exam. That varies a bit depending on the activity. And then there is often some type of post-encounter activity that we will talk about. What are some of the benefits to using this as a method of observation or assessment? Well, there's a feeling that there is greater objectivity. That is, that it's not just because I like you and I think you're doing great that I'm going to give you an honors on this particular exam. There are criteria that you have to meet. There is standardization, as we talked about. And there's a high level of reliability and validity. As you can imagine, that every student in the United States has to go through this exam. That the Step 2 CS exam was initiated in 2004. That's a lot of data. That's a lot of data that's out there. And the NBME, as Mike can attest to, is really rigid and rigorous about their data collection. So there's a lot of material that's out there based not only on the US exam, the Canadian exams, but also the ECFMG for foreign medical graduates prior to the CS being initiated did a similar type of exam. It is particularly good for communication skills, and I think anyone in here who has either taught communication skills, motivational interviewing, all different kinds of learning that way, they will know that this is actually a great methodology for teaching that and assessing it. Yes, it is a motivation for learning. It's not just because it's a test, but in the moment, How many people in here have actually used SPs to teach? Okay. How many people have actually been as a learner in a learning situation with SPs? Okay. For those of you who acted as a learner, what did you feel in the moment about being with an SP and having one of those experiences? Think back, either a testing or a formative experience.
In the beginning, it felt a little weird, but pretty quickly I almost forgot it was a standardized patient.
Okay. Why did you forget that it was a standardized patient?
I think because I probably got caught up in the natural conversation that happens. I think social etiquette and just kind of habit takes over, and you're just talking to a person.
Okay. What else, please?
It's also slightly anxiety-producing. Usually observed by people. That may be a benefit. There's like a heightened emotional state. It's not just like talking to a person in the hall. It's a built-up experience.
Right. Right. Anybody else? I mean, you do, partly because of the anxiety, you remember those experiences really well, and you remember what you didn't do well, right? You also remember what you did well, because you hit that aha moment. Yes, you do. You do remember what you did well, right? See, Jason says yes, right?
I did one of these 12 stations, and I don't remember any of the cases except for the woman who had somatoform disorder. She was a medical student. I did really well in that case.
Gee, I wonder why, Jason. That's standardized patient. See, life-changing, these things, if it can be. For those of you who have taught with standardized patients, have you had the opportunity to see where a student has gotten that gap in their learning? Like they can see where they've learned or what they need to learn? I think, anybody who teaches, especially for me, teaching in any of the interviewing courses, there's this like, oh my gosh, I did this so badly moment. Can I go back and do this again? And they've learned how to do it, and they do it well. And they don't make that mistake again, at least that we see. And so that's actually a really good motivation for learning. And students and learners, in the end, are actually really satisfied with this methodology. Yes, it is anxiety-provoking. There's no question about it. But most students will say, I felt like, depending on the experience, and that's true of any experience that we design curricularly, that they do have great satisfaction with this. And there's a lot of areas for potential testing, right? There's knowledge, there's clinical skills, the history and the physical exam taking. There's problem solving and diagnostic reasoning, and certainly a big part now of the clinical skills exam is the patient management and counseling. That has actually taken over as the larger part of what the students are scored on at this point: communication, patient management, and counseling. And this guy probably did not do so well on the exam. So validity, as it's sort of defined, is this issue about whether or not a test actually measures what it is supposed to. And there is kind of concurrent validity that is in terms of whether or not it's congruent of other things, that other measures of student performance, and then predictive, and can tell what students are due in the future. There's been a lot of question about whether or not this is truly predictive. Based on the Canadian model, what they found was that students who were doing poorly on the communication and counseling parts of their equivalent to Step 2 CS actually ended up more frequently in front of the licensure boards down the line with complaints. So there is some predictive validity to that. It turns out that also in terms of reliability, whether a test reproduces the findings from time to time, time after time, certainly inter-rater reliability can range quite a bit. And it does require some training on this. There are There is good internal consistency typically, however, and test-retest has turned out to be pretty good. The reliability factors, when they've looked at it across a variety of settings, is best in the history taking portion of it, ranging anywhere from 0.78 to 0.97, depending on which studies you're looking at. But the physical exam has probably in the 0.7 to 0.8 range as well, depending on which physical exam you are doing. Double checks can be often difficult to do. You don't always have two observers watching a student during an exam, but actually you can use SPs to train them as well, to actually, on a checklist, tell whether or not a student did or didn't do something. And this idea of test-retest helps to determine how reliable a station, any given station, is. It can be affected by poor patient performance. So if a patient's having a bad day and they're not reliably saying the same things time after time, it can actually be affected by that. And that's a caveat to using this methodology. Now, there are some clear disadvantages to using OSCEs. One is it's stressful, and maybe that's good, maybe that's bad. You're on your best behavior in theory while you're doing this, and so you're probably, you are hopefully, let's put it that way, doing your best and showing what you can do. What we find is over time, if maybe you're great or maybe you're not so great on your first station, bad habits die hard. By the end of the exam, we usually know who's not doing so well on some of these things. It's very complex. I don't know how many of you have ever been down to see one of our CCAs or one of our OSCEs. It's a production. It is a production from 6 o'clock in the morning till about 6:30, 7 o'clock at night on any given day that we're running this. There has been a concern that it undermines the holistic approach to the patient. That is, you are focusing on one aspect or one particular problem rather than looking at the whole patient. The counter argument to that is that's what you do in a 15-minute visit as well. Many of you know that the OSCE, the grading in the OSCE, is based on a checklist. And the checklist is a very difficult thing to create. How many of you in here have ever created a checklist? It's a pain in the butt. Why? Why, Mike? You've created a boatload of them.
If you have a whole bunch of things, you lose reliability. And then if you only a few checks, then you don't get enough depth to your evaluation. So you have to hit that sweet spot, which is like 8 to 12 items.
Yeah, and not to mention the fact that you cannot put two things on one line, right? So when you are introducing yourself, for example, if one of your goals for this station is for the student to always introduce themselves properly, you cannot have on the same line that the student introduces themselves and washes their hands. That's 2 items on your checklist. That's not 1 item, that's 2 items. And for, as Mike said, probably 8 to 12 items is great, but realistically, an SP cannot remember more than 25 items in a station. So if you have more than 25 items on your checklist, get rid of whatever is above 25 because you're not going to get the SP to remember that. That's where that number comes from. So you really only want the most crucial items for that station on there. So maybe the introduction is not the thing for that station. Maybe palpating in all 4 quadrants is, or maybe counseling the patient that they should not be drinking as much as they are, whatever it is, only the crucial items should be on there. And the other problem with checklists is often, do you have done, not done? Done incorrectly, not done? Maybe a 1 through 5 grading scale. How do you want that done? And when you do done and not done, or done correctly, you have to define that. And that's actually a really tough job. I think that Val Fulmer, who is here, who's our standardized patient director and trainer extraordinaire, will tell you that we get a bazillion questions on the checklist, even when it's like reflexes. Does that mean checks reflexes? Does that mean checks the patella, the Achilles, the brachioradialis, the triceps, or does it just mean checking one knee? What constitutes done? And they will ask you that, by the way. So from your standpoint, as faculty developing a case, you want to have a blueprint of the material that you want to cover, whether it's one case or whether it's 10 cases. You must have clear, behaviorally based, that is, can be observed, can be quantified, objectives, and a clear, behaviorally based checklist. Now you can do variations on a theme. Abdominal pain. You can have pain up here, you can have pain up here, you can have pain down here, you can have pain down here. It's all the same case, it's just the location changes a little bit. So you got 4 cases out of one base. However, from an SP, now remember, most SPs do not have a healthcare background. These are lay people. Many are actors, but not all. Coming from all walks of life, all ages, lots of different backgrounds. So you have to write it in English, not medicine. And that's actually a really tough thing to do. We are fluent in the language of medicine, but our standardized patients are not. All of the appropriate sections have to be scripted out, including any emotional tone, that kind of thing. You have to indicate what and when the SP can offer certain information. So it's not like they're just going to be a font of information. The student, the learner, has to prompt them to get certain things, and you're the one guiding that when that happens. You can list some sample responses that you do or don't want to see from students and how an SP might be able to respond. And you really have to make sure the information is consistent throughout the case. They can have quit smoking 3 years ago in one part and still be smoking here. And by the way, the SPs will pick that up and bug you about it. All right. You cannot test or teach all of whatever your respective field is in one case. All of internal medicine does not go into one case. All of psychiatry does not go into one case. You have to decide what you feel are the most critical points for each case and make sure that your co-faculty agree, because there's a lot of disagreement when it comes to these things. Make sure that the case is cohesive and congruent. And oh, by the way, did I say clear and behaviorally based, which you will hear me say at least another time or two. All right. I've talked for a few minutes. I want you to take about 5 minutes now. You can be antisocial and do it by yourself, or you can pair with the person next to you. I want you to do a couple of things. First of all, if you're going to develop a case, you can decide if it's teaching, testing, whatever. Determine your learner level. Write one behaviorally based objective for a case. That is something that could be observed and done. Determine what your setting is. A bullet point description of your SP. Are they male, female, distraught, not, disheveled, not? And I want you to write the opening line or answer for what brings you in today. And you've got 5 minutes to do that. Go. I'm timing you. All right, so as you can see, there's a wide variety of things. Interestingly, as this was set up, mainly to talk about kind of communication skills, but in about 5 minutes, actually 4.5, you were able to come up with a skeleton for the case. Now, let me just point something out. That was a skeleton. This multi-page template is actually what we do. One case. This is it. Okay. Now, you know, how well you develop some of these is dependent on the stakes of the exam. A case completely filled out in that format would be for a high stakes. We certainly have smaller cases than that. But as Val can tell you, the more you fill out on that, the less questions we have to ask you in the end. So it's actually very important to understand that there's a lot that goes into developing these cases. Often post-encounter, there will be another type of event. You may have some peer feedback, particularly if it's a teaching encounter. Self-reflection, faculty and SP feedback can be given as well. Often in a summative format for OSCEs, there may be an oral presentation or a note or some type of alternative exercise, that is interpreting x-rays, listening to heart sounds, things like that. Giving feedback, everyone in here is extremely experienced at that, but whether or not it is written or oral, it must be behaviorally based. And that's true for whoever gives that feedback, whether it's the SP or the faculty. It needs to be brief. Nobody wants to listen to a 20-minute diatribe about what they did wrong. Congruent with your objectives for that case. And based on the checklist items, often helps it to be very behaviorally based. So what they did incorrectly, didn't do, or did well, if it's on the checklist, that can be very helpful to guide the feedback. When SPs are giving feedback, we ask that they only give it from that patient's perspective. That is, that they stay in character to give the feedback. Again, based on the objectives and the checklist that you have designed, and it's really excellent for interpersonal communication skills. When you said this, you made me feel this way. And nobody can know that but that particular patient. And again, it's behaviorally based. We train our SPs to be that way. This is compressed form, but this is actually the note that the students have to fill out after Step 2 CS. This is the new note format. They have to give the history, the physical exam, the diagnosis, 1, 2, and 3, and the history and physical exam findings that support or negate that, and then they have to do diagnostic studies. So this is actually the note we have our students filling out at the end of Step 2 of the CCA, the mock Step 2 exam. And we're trying in many formats to get students to at least be thinking this way when they're on their clerkship. But again, there may also be an oral presentation. That's actually how family medicine does their summative OSCE instead of a note. Evaluations, as we know, there are many parts to an evaluation, and there are actually many parts to what we do with our SPs. The more specific anyone is, the more helpful it is actually for the students. And written comments are invaluable. For our high-stakes exam, we give written comments from the SPs on each of the cases about what someone did or didn't do well. You also have to determine what constitutes, if this is a summative exam, pass, high pass, and honors, and that's a whole nother topic. And then what are you going to do when they don't pass? And let me assure you, there's equal amount of work that goes into that process. So what is possible using SP methodology? Almost anything. I know Val doesn't want to hear me say that back there, but it's true. Almost anything is possible. What are we currently doing? Well, here at the Schools of the Health Sciences and beyond, on interviewing and communication skills, anywhere from basic to advanced. We do GYN and GU. We actually use standardized patients for teaching those very sensitive exams. The physical exam, we go from MS1 to CME and beyond. We have medicine, nursing, pharmacy, dental, PA programs. We have worked with the business school. We have worked with many other institutions actually within the city and beyond. Certainly we've worked with the VA and are looking forward to working with them even more. I could show you that we have a 2-page, I think 8-font activity list of what we're involved in right now. But that doesn't mean that that's just, what's possible that's out there. And technology, and I consider SP methodology a form of technology, is great. If we could fix everybody with Photoshop, that'd be pretty darn awesome. But it certainly has its limitations. And I have to say, first off, that the SP program at Pitt is considered one of the nationally recognized programs. That is due to the work of Val and Amy and all the staff in the Advanced Clinical Education Center. The reason that they got there, though, is that our SPs, all of them, all 135 of them that are currently active, have a base training. Every single one of them goes through 16 hours of base training. They then have to go through training for a given role, including self-study. It is very challenging to use lay people as healthcare professionals. So when we talk a lot about the interprofessional activities, using lay people as nurses, as doctors, etc., if they don't have that language, very challenging. That being said, our SPs who have been around for a really long time could practically graduate from medical school at this point. They've all had strokes, pneumothorax, a wide variety of emotional complaints. They're psychotic 98% of the time. I mean, we've got a lot going on. So they're good, but they don't have that degree. It costs, guys. There is money and, as you can see, time highly involved in this. And so it's got to be, the activity that you're doing has to be worth the cost. What can be simulated? Well, not everything can be simulated. I think our highest thing that we simulate any person is a pneumothorax. Now let me assure you, not the chest tube part, we're not putting that in, but that's actually pretty darn challenging. And there's a lot that can be simulated by a person, but there's only so much. Given this degree of complexity, quality assurance is huge. And we actually have a very rigorous quality assurance program that we've put in place. Not every SP program has that. So I guess with your experience now and knowing how you've used it, the question I'm going to throw out to you is, what might you see as the next area for research and scholarship using SP methodology? So, I think these are all really fascinating ideas, and I actually put out a poll to the ASPE listserv, and there is a lot that's out there that's come up in terms of interprofessional education. We've actually done a project using standardized colleagues to teach pharmacy and nursing students about difficult interprofessional communications. There has been, the University of Kansas has done simulated interprofessional rounding and error disclosure, actually. So for patient safety, this is a big area of research. Researching how to diversify SP pools. Doesn't matter where you are, but getting minorities to be SPs is actually very challenging, even at traditionally minority-rich institutions. Sociocultural issues and cases, things like transgender, gay, lesbian cases, that kind of thing. Whether or not how we develop a master curriculum for training SPs, like a standard program for that. Remediation or pre-mediation, as I like to think of it, of students and SPs. There's a lot of research that should go into that. And then, of course, this issue of hybrid simulation versus straight simulation. What's the area, what works best where. I have to say that in my own personal experience, I have learned so much from using SPs about authenticity, about a common language, because we have to remind ourselves constantly how to speak to patients. I think every time that I use them, I become a better healthcare professional. Because it has taught me, it has reminded me about the skills that we are teaching our learners. And they teach me to do things differently. They're like, well, why don't you do this? Or why don't you do that? Okay, that makes sense. So let's do it that way. And if you listen to them, you get some really great ideas. So I think the take-home points from this is that SP methodology is one in a vast array of tools for teaching and evaluating learners in a variety of skills, particularly in communication, but there is a boatload of stuff that we do. Everything has to be behaviorally based. I said I was going to say it again, and I am. The checklist, the learning objectives, the feedback, but it's very worthwhile. It is a complex but extremely rewarding field for research and scholarship. I mean, there are a lot of great people out there who have made their careers in it and can make their careers in it. And as I said, we are so fortunate at Pitt to have this amazing advanced clinical education center with the most incredibly well-trained SPs that are very open to feedback. We have an amazingly prepared staff that will assist with formulating the cases after at least the first draft or two. You cannot come to them with what you just did, I assure you. And that they're there to make sure that your goals are met for whatever your session is. And so I can't do my job without them, and none of us who use SPs can do the job without them. So if anybody has any questions, we have a couple of minutes, but